80% of the deaths occur within 48 hours. 80% occur within a week.
Some of the
I'm excited that you're here. Thank you for being here. Thanks for all the great.
So the definition that I would hold in my head is a failed vaccine.
Hello, welcome to episode 7 of COVID Revealed. This is a 9-part docuseries, and now we're in that home stretch of the last 3 episodes. I'm excited that you're here. Thank you for being here. Thanks for all the great feedback that we've gotten along the way. I gotta tell you, this was a tough thing to put together, and not only that, it is tough to put it out in the world because of all the adversity that we get in trying to do so. So your encouragement means the world to us. Thank you for that. It really does matter. Keeps our spirits high, keeps us going. Thank you for being here. Before we jump into episode 7, I just want to remind you that you can own COVID Revealed. We're in the free viewing period right now, and during this free viewing period, we have significant discounts on the varying packages that we have when it comes to COVID Revealed, and we also have some significant bonuses that I think you'll be very interested in. If you've already purchased it, thank you for making that investment. It encourages us, it gives us the resources to keep going, and I have to tell you, when it comes to this subject, we need to keep going, we need to keep producing, we need to keep this information out there in the world. So thank you for being here. I know you're gonna love episode 7, let's go. Welcome to part 3 of my 3-part interview with Dr. Peter McCullough. Being in the presence of this man and having dialogue with him is an extraordinary experience because of the depth of his experience and his intelligence and his passion to share this information with the world. It's amazing that people like him are getting censored when they're the ones that should be speaking most and being heard by the masses. So I'm glad that we are here right now, you and I, so that we can share this information with you and you can understand the truth when it comes to COVID. Let's jump into this interview. Is it true also that some of the data that they were using to say that we have an epidemic of the unvaccinated or pandemic of unvaccinated, that they were taking that data before the vaccine was really distributed very much also? That's, I had one person talk about that the time frame from when they took, said, here's the amount of people in hospitals with COVID, and this percentage are unvaccinated, but very few people were vaccinated at that point in time. So of course, most people are gonna be unvaccinated.
Sure, if one takes a longer range, actually in the Havers paper, they do it month by month. So that's the reason why I just mentioned June, because there's no sense mentioning back in, January, where the majority is unvaccinated, of course. And obviously before the vaccines, it was all unvaccinated.
Right.
So I guess what the listeners are probably gathering is the vaccines don't work well enough in all people to have this be a central tenet. We need 4 pillars of pandemic response. We need some ways to reduce spread. We clearly need early treatment. We need good hospital care. And that we need some form of immunization. We have 75% of those over age 65 vaccinated. They took the risks, they did it. We have about 40% overall of the general, under 65 population vaccinated. My personal and professional opinion through all this is I think those numbers are too high because the vaccines were unproven, because we had concerns about a dangerous mechanism of action, that a limited program to those at the highest risk, seniors, maybe nursing home workers, where we had clear spread. We never had any outbreaks within hospitals in general. We never had outbreaks in schools. We never had outbreaks in many big employers. There was a couple here and there, but we didn't have clear-cut outbreaks in airlines, travel, et cetera. If we would have taken a narrow focus on vaccination, we would have kept our safety concern numbers down, and we would have handled those at higher risk. But to just have this broad sweep across the population, we've really, really incurred now what I think many would consider as a catastrophic biological safety program on our hands. We have over 13,000 deaths now. Not 186, 13,000 deaths reported in the VAERS. We have over 545,000 total injuries. We have over 10,000 permanent injuries, where the reporter thinks it's permanent. We have over 200,000 hospitalizations, ER visits, urgent care visits. The vaccine is really prompting things. We have 2 good external analyses published and available to review, and all the people listening to this should review. One is by McLachlan out of London, and one is by Rose out of Israel, taking the VAERS data. This is what they've learned. 50% of the deaths occur within 48 hours. 80% occur within a week. 86% of the time, there's no other explanation. They're tightly temporally related. They're very internally consistent over time. We know going to the yellow card system in the UK, also very, very tightly related. So tightly related that the evidence-based consulting group in the UK, a principal consultant to the World Health Organization, has messaged the MHRA in England to say, listen, shut down the program. The vaccines are not safe for human use. There was a group out of France very early in March. They recommended shutting down the program early. I'd say the evidence-based consulting group was next. There's a paper by Bruno and colleagues, 57 authors, 17 countries. I'm in the author block. Didn't take that strong of a stance, but said, listen, if you can't get the safety data reviewed by external panels, shut down the program. Take a pause until we can figure out what's going on. You know, on 2 occasions, the CDC has put on their website a statement in March and in June where they said CDC and FDA doctors reviewed all the deaths and none were related to the vaccine.
None?
None.
But that can't, I mean,
It can't
it's
be, right?
disingenuous,
So
right? I mean, it's
it
lying.
it just can't be. I
So
mean,
how do we trust the CDC if they're willing to lie like that? How do we know what to trust?
I mean, the term for performing actions where it must be wrongdoing in those of position authority, that's called malfeasance. Now, if you were in their position and you said, listen, we have one thing we're offering America, a vaccine, that's it. We're not offering treatment. We've got to get a needle in every arm. And whatever we do, we can't make people hesitant. We just have to float this out here and say the vaccine's not causing the deaths. If you take their perspective, they would have to. You know,
But that's the moral philosophy of the ends justifies the means,
Right.
Which is about as vile a thing for humanity as one could imagine.
listen, it's a moral hazard, right? It's a moral hazard. We know the Trusted News Service came out early in December, as broadly announced, BBC, other major media. They said, we will do everything to promote this vaccine. We'll do everything in the media, social media, to crush vaccine hesitancy. That means crushing early treatment, anything on vaccine safety, anything on vaccine side effects. It made sense because anytime someone tried to report something going wrong with the vaccines, it was crushed.
So that's the very definition of propaganda, right?
Well, propaganda is a little different. The propaganda is false information put forward by those in position of authority. So I'll give you the best example of that. That's the August 23rd FDA meeting to evaluate Pfizer data. So what happened there, when you're coming down to a approval that's going to be permanent for a product, I've done this before, so I'm really, know what I'm talking about. There is a full briefing booklet by the sponsor. They give the data to the FDA. There's a briefing booklet by the FDA. They have to be reconciled. Something big like an approval for a vaccine that's going to be broadly applied, full advisory panel, public citizen commentary. There was already letters in. There was a physician letter in and a nurse's letter in to the FDA for non-approval. Said, listen, didn't look safe. The physician one was led by Linda Wastila out of University of Maryland, very well-respected group. So those were already on base. But as this meeting was moved up, it met August 23rd, no briefing booklets, just some letters that were generated out of there, no advisory panel, just some letters. The letter that was generated to Pfizer was a continuation of the emergency use authorization. There was a splitting of the product into BioNTech, which is the German company. The understanding is from those letters that they're legally distinct, medicinally potentially distinct with minor differences. BioNTech got the conditional approval with a lot of stipulations for post-marketing studies to be done on myocarditis, a lot of cautionary word about pregnancy, knowing there's a lot of unknowns in pregnancy and harms to the mother and the fetus and what have you. And so the draft Comirnaty package insert was drafted, but Comirnaty and BioNTech don't have a product in the United States, and that proposed label is not yet finalized or approved. But the talking point that came out of the meeting, and this went all the way up to the President of the United States, was that Pfizer was approved. And that is propaganda.
That's propaganda.
That's just flat out propaganda. You can't do that. You can't say a product's approved when it wasn't.
But isn't it propaganda to say there's not one death?
Well, I mean, the deaths did occur. They're saying it didn't happen to. So the frustration is extraordinary. So you can imagine using CMS data and extrapolation from CMS. In June, I believe, attorney Tom Rentz filed a federal lawsuit, claiming up to 45,000 deaths at that time due to the vaccine. That there should be a temporary injunction or a restraining order, shut down the vaccine program. So that lawsuit's very important. You talk about numbers like this. I mean, remember 9/11, 2,000 people, and it's just an American catastrophe. Can you imagine if it's really 45,000 American lives lost? Now, you brought up the issue of moral hazard, and people have said this. They said, Dr. McCullough, COVID is a bad illness. We've lost 600,000 Americans. Listen, America should be prepared for this. I did a show with Dr. Drew, a TV personality, Dr. Drew, and he goes, I think America was prepared to lose lives with the vaccine program, mentally and psychologically prepared. If you go back, our CDC had sketched out some estimates. They thought we were going to lose 1.7, 2.1 million Americans due to COVID-19. The early treatment push really kicked in November, December, historic Senate hearings. That mortality pretty much arrested in the 600,000 range. We didn't race all the way up to 1.7 million, okay. And we know now from the Pfizer data that was evaluated at the August 23rd meeting, no mortality benefit from Pfizer, even on the legacy variants, even on the variants we thought the vaccine covered. That meeting didn't review any data on Delta. And I told you we're 99.1% Delta. So everything that happened in the August 23rd meeting is fundamentally irrelevant because we now have the Delta strain, and the data look vastly different on vaccines with Delta. The Israeli Health Ministry has an estimate on Pfizer at 39% protective. Mayo Clinic has Pfizer at 42% protective.
And by protective, do they mean that prevents death, prevents hospitalization?
It's an estimate of vaccine efficacy. No, that's just the binary occurrence of COVID-19. So that's just an estimate. It's, in a sense, it's a population way of getting to vaccine efficacy. So if out of the clinical trials it was 90% with the original Wuhan wild-type protein variant and maybe the British, now we're at 39% Israelis, 42 Mayo Clinic, 44% British REACT data.
They're saying prevent you from getting COVID at all.
Just, protection.
Okay.
And clearly Israel and the United States have announced now boosters sooner than a year. So the definition that I would hold in my head as a failed vaccine commercially would be doesn't have 50% protection in the community and can't last a year. I think everybody should understand that it looks like Pfizer's failed. Of interest, Pfizer is 30 micrograms of messenger RNA. Moderna is 100 micrograms. Mayo Clinic has Moderna at 72% protection. So what I've said is, listen, America was owed every week of the program FDA and CDC officials to come out and review the data. What are we seeing? How many Americans vaccinated? How many breakthrough infections? How many safety events? And then monthly, we needed detailed press briefings and reports. And we needed guidance from those agencies to guide us, what's the best vaccine and how can it be safely administered? And to this day, we're in September 2021. They haven't come out with a single press briefing with the data. With the data. It's now just unsupported talking points. And I'll tell you, the label should be misinformation from our agencies. Here's another example. Our head of the National Allergy and Immunology Division and our Surgeon General have both said, with a straight face on TV, that the vaccine immunity is better and stronger and superior to natural immunity, where there is 15 studies showing just the opposite. In fact, as the vaccine failures pour in, obviously Israel is an 80% example of vaccine failures. Iceland's no different. The UK, very similar. As the vaccines are grossly failing, we are hard-pressed to find a bona fide case of natural immunity failure. There's about 100 cases out there that maybe the patient could have gotten it a second time. We look at it carefully. It's not the case. I basically just reviewed a case today with the person who contacted me, thought they had it, and after we walked through everything, we think actually the first case was influenza, the second one was COVID-19. To my knowledge, there has not been a sick person, certainly not in the United States, really sick with proven COVID-19, PCR, antigen, sequencing, sick in the hospital on the ventilator here, and then sick in the hospital on the ventilator, same sets of confirmatory testing, let's say 6 months over here. Hasn't happened. It's all been a little smoke and mirrors, probably confusion based on false positive testing or cross positive testing, not a bona fide case. And the bottom line is when we see a challenge to natural immunity, Cleveland Clinic study, which is Shretha and colleagues, again, information, not misinformation, information, unvaccinated, COVID recovered patients, go out in the workplace, Cleveland Clinic, 0 cases of reinfection, 0.
Is it dangerous, potentially dangerous and I don't think it's been studied, that a person who's had COVID, naturally occurring COVID, went through back to health, that now you vaccinate them after their immune system's already geared up? Is there a potential threat there? Because now they want to force workers in the United States to get the vaccine, and they're not discriminating whether you had COVID or not.
Well, the FDA and Pfizer, Moderna, J&J always traditionally excluded COVID recovered from the clinical trials because they figured, here we go, they've already had the virus, they've already had some damage to the spike protein, somebody could have been sick with pulmonary involvement, we know the spike protein is damaging, spike protein damages blood vessels, causes blood clotting, spike protein gets into the brain, gets into the heart, we're gonna have trouble, right? So the exclusions, you have to pay attention to the exclusions. The exclusion criteria were agreed upon by the FDA and the sponsors. COVID recovered, suspected COVID recovered, those with positive serologies, pregnant women, women of childbearing age that can't guarantee contraception. That's a broad exclusionary panel. And those exclusions are certified and approved by investigational review board. So we have external people agreeing on it. Because you have to actually justify why somebody's excluded. No opportunity for benefit, excess opportunity for harm. Perfect. That's the way it's supposed to be. They did the right thing. I told you the original registrational trials turned out okay in terms of good enough to get out there and use. Why are we in such a safety biological catastrophe right now? Maybe it's because we're not following the inclusion-exclusion criteria of the trials, which we always do. So here we go. We have 3 papers, Raw, Cameron, Methodius, showing if we vaccinate on top of somebody who's already had naturally recovered. Again, they have no benefit from vaccination. We just do it anyway. Higher rates of safety events, including hospitalization. We have data, pregnant women. Again, a dangerous mechanism of action. Anything that we think is dangerous. Let me give you an example. Chemotherapy. If I said we're going to give a pregnant woman adriamycin, someone would say, wait a minute, that's pregnancy category X. That's a damaging chemotherapeutic agent. That's a toxic agent. I'd say, yeah, it's pregnancy category X. Shouldn't do it. If we have a product, messenger RNA or adenoviral DNA, and we know it creates production of the spike protein, and we know the spike protein is damaging, this is known. We're injecting a known biological active substance in a pregnant woman. That is out of bounds. We never do that. It's pregnancy category X. There was a paper from New England Journal of Medicine that came in that looked at different windows and timeframes of women from the VAERS and BSafe data on vaccinated pregnant women, which shouldn't happen.
Right.
And there was concern in the first trimester about excess fetal loss. And some debate because we couldn't really get the denominator. So letters got sent into the New England Journal of Medicine. I work with a group of Canadians. We sent one in expressing concerns because that rate, instead of being a purported 12% or 13%, could be as high as 83%. Depends on what denominator you use. In the end, the idea is, well, we're not really sure, so our letter wasn't accepted. We published in Trial Site News, which is a wonderful way to publish information, not misinformation, information for people to go read and decide themselves. We lay out all the statistics, and we make a case that the vaccines in pregnancy should be pregnancy category X, that it's, listen, we don't have enough safety data to say we can do this. Subsequently, just in the last few weeks, there has been a modification to that paper published by the authors in New England Journal of Medicine saying, listen, we can't really be sure about the safety in the first trimester. But that hung up there for months. Okay. Our director of the National Allergy and Immunology branch of the NIH has said multiple times on TV, we don't see any safety signals in pregnant women to give the vaccine. There's been a paper by Pinellas and colleagues, again, information, not information, Pinellas and colleagues, Annals of Internal Medicine, showing that pregnant women who get COVID-19 have better outcomes than non-pregnant women the same age. So pregnancy is, and if a woman does have severe symptoms, it can be easily treated with the drugs that are safe in pregnancy. So, I hold the view that we should always strictly stick to the science, stick to the exclusionary criterion of randomized trials. I would never use a brand new product with a dangerous mechanism of action in pregnant women. And shockingly, the American College of Obstetrics and Gynecology recommends that pregnant women take the COVID-19 vaccine.
It's inexplicable.
It's inexplicable. The same argument can be extended to children.
I was just about to say, now, is it crazy to say that we need to go vaccinate children? And what is their real risk? And, because teachers are saying we don't want kids coming to school that are unvaccinated.
Well, to be fair, there's a great concern that, Delta is a pandemic of youngers. As older people have already gotten COVID, and sure, there are younger people. We knew that before Delta was shading in. The percent turning positive was heading towards younger and younger individuals. But what's clear is we've never had any major school outbreaks in the United States or elsewhere. We've never had well-documented large numbers of student to teacher transmission. It's well known that children have, in general, mild COVID-19. They, in a sense, become an immunologic buffer. It's known that large numbers of them have already had COVID-19, could have been a cold or otherwise. It is known that it's very treatable in children with, if they need, inhaled steroids or systemic steroids, azithromycin, other things to kind of help a child get through the illness. And it's well known that the mortality's been reviewed by a couple separate investigators. That there were some mortalities in children, and so far in the pandemic, roughly 300. The vast majority, outside of one, was really highly attributed by other problems like cystic fibrosis or underlying cancer, et cetera. At the same time, there were many-fold increased numbers or higher numbers of strangulations or traumatic deaths. So COVID-19 is a very, very minor threat to children. So with that backdrop, one could say, listen, why even do clinical trials in children? We got bigger fish to fry. We got adults we're worried about. But clinical trials were done. Frank and colleagues published in New England Journal of Medicine May 27th, 2,200 patients, randomized trial. Pfizer, same dose, 30 micrograms in children aged 12 to 15. It did prevent 18 cases of mild COVID-19, in a sense of 18 cases of the sniffles. There were no reported child to family or child to teacher spread, which could have been a secondary benefit. None of that was reported. And about 60 to 80% of the children had serious side effects: high fever, muscle aches, body aches, kept out of school, etc. It was not easy for the children to take the vaccine.
That's an argument that they shouldn't be vaccinated then.
My clinical interpretation would be no compelling clinical benefit, right? No mortality or hospitalization reduction. Nothing to suggest that there's even a secondary benefit of vaccine. Again, FDA, I told you the data were published May 27th. FDA ruled on this May 10th, just by looking at the antibody response data in a letter back to Pfizer saying approved EUA for injection into children. Talking point, children can now get vaccinated. It's my interpretation is that there is not a clinical benefit, and there's only an opportunity for safety concerns, and the FDA agrees in a sense because of the myocarditis risks that are now put on children and younger adults, men more than women, of having heart inflammation because of spike protein. There's a preclinical paper now published showing the spike protein does get into the heart muscle and the supporting cells, the pericytes. It expresses on the cell surface. The body attacks our own cells. Then the spike protein circulates. This is the last thing, as a cardiologist, I'll tell you, the last thing you want in any human heart is the expression of spike protein. There's just no way that can be healthy for children's hearts. As we sit here today, the VAERS has over 5,000 cases of myocarditis.
Wow.
This morning, there was a report out of Toronto that Toronto hospitals have 200 kids in Toronto hospitals, in the hospital with myocarditis. I mean, this is really concerning. Myocarditis is EKG changes, troponin elevations, chest pain, early heart failure. Some have incipient heart failure with reduced ejection fraction of the left and right ventricle, require medications, require follow-up, have to stay out of activities. I mean, this is really alarming. Separately on J&J, there's warnings now that span a broad age group on blood clotting in the brain, central venous thrombosis, cavernous venous thrombosis, paralysis, what's called Guillain-Barré syndrome. The official warnings there have been a lot of reports on neurologic injury across all the vaccines, lots of reports of thrombotic events across all the vaccines. As a safety-minded clinical investigator, I am greatly alarmed that our agencies have given no comprehensive safety report to Americans.
And further, no informed consent because they don't want to create vaccine hesitancy. They don't even want people talking about this. They don't want the information. They don't want you to say what you just said, basically, because it might cause hesitancy on the part of these people. But isn't informed consent the fundamental moral tenet of the doctor-patient relationship, saying, before I do this procedure on you, you should understand the risks that are involved, and then you can make a decision about your own body and your own life?
Well, the vaccine program currently is investigational. Anybody listening to this will know if they've been a research subject, typical research consent form is about 25 pages long, and it lists everything that can happen.
Yeah.
And it's very comprehensive. And here, because not everybody is checked for these problems, we can't state any of these are rare. And I think it is disingenuous for any public health official or academic person in the setting of this pandemic response to declare anything rare. Because unless we check everybody for myocarditis, and we check everybody for blood clots, and we check everybody for allergic problems, we don't know. It's just spontaneous reporting. The conservative, safe, reasonable thing that a reasonable physician investigator, a reasonable clinician would do, is say, listen, this could be the tip of the iceberg. We're only halfway into Americans with most of these data. As we continue to push, remember, a lot of people haven't taken the vaccine because they don't think they can take it, that they don't do well with other vaccines. They have allergies. They've already had COVID-19. They know that they can't benefit from it. They could be harmed. So the next, if we're going to push for the second half of Americans, I can tell you, I would wager to say that we're going to see even greater numbers of deaths, hospitalizations, and serious safety events.
Is it reasonable to assert that we haven't had the vaccine out long enough to really understand? Because we can talk about, death happens pretty quickly, some of these more acute type of responses or myocarditis, other such things. But as you cited earlier in this interview, for gene therapy, typically it's a 10-year cycle of data and research to know the real safety and long-term effects. Is it possible there could be a lot of unknown chronic effects that we won't know for years at this point, that this has been a mass experiment?
I think most clearly a mass experiment. I think that's a fair statement. If it was just one shot and you tried to get the best immunity and that was it, I think people's comfort level would be a little bit higher, saying, okay, I took a one shot, I tried to get some protection. Now it's 2 shots, and now a 3rd shot, and now a 4th shot. Well, I gotta tell you, if it gets to be regular injections, now we're talking about regular gene therapy. I mean, these were originally gene therapy products to be given once a month, maybe once every 3 months, once every 6 months. Now the question is, what good are we doing by keep having the body remake the wild type spike protein?
Yeah.
Or what if, from shot 1 to shot 2 with the messenger RNA products, it was about an 80-fold step up in safety risk. I don't know what shot 3 is going to look like, and keep having the body produce. My clinical intuition to say, listen, I'm concerned. But we're at a good point to talk about information and misinformation and the Federation of State Medical Boards.
Yes.
And the American Board of Internal Medicine and the other related medical specialty boards. They have put out very serious warnings, really to doctors as myself. I have a medical license. I am multiply board certified. And the message is that there will be strict disciplinary action taken against physicians with respect to COVID-19 misinformation, specifically on the vaccines.
I'm really glad you brought this up, because here's what I'm finding, at least. You are a very public-facing figure now, and have gained a lot of attention. Wanted or unwanted, here you are, an unlikely hero of a cause in many respects, and of course a villain to people who have a different agenda. But the thing to understand, I think there's a lot of people who are silent right now, practitioners, licensees, who are under the thumb of regulatory agencies. A doctor needs a license to practice. A specialist, has their specialty organization, the cardiology, et cetera, which, these are hard-won credentials to have, a lot of time, effort, energy, et cetera, to create them, to achieve them, and they become the basis of livelihood for a person like yourself. And now they're starting to create that threat, saying, we don't want independent thinkers as doctors. We want you to carry we have an agenda, and if you feel like you don't align with this agenda and you speak about it, we would take away your credentialing. That's a real threat, and that's got to be sending a chill up your spine, and I'm sure a lot of other people who maybe are like you, saying, I'm seeing these patients every day. I want to do early intervention, and I know it's not recommended. At the same time, I'm seeing people maybe who I don't think, the risk of the vaccine versus the real risk of them getting, really sick from COVID, I can't recommend it for them. I took an oath. But now they're saying, forget your own conscience, forget your own expertise. You're going to do what we say, other we're going to rip your credentials away. Is that pretty much the environment that's evolving?
It's enormously threatening, and I want the listeners to understand that scientific discourse and exchange on a topic of public health importance is actually legally protected. Mm-hmm. You and I have the right to do this. We're not talking about someone's personal life. We are talking about knowledge, scientific knowledge. And if you and I wanted to have a debate about computer circuits, you and I could do this, or a scientific debate on global warming. We have the right to do this, right? We have the right to have an interchange when it's of public importance and it's not personal or have any ill intent. No one is attempting to harm others. We are trying to get to truth. I've taken every vaccine that I'm supposed to according to vaccine schedule. I've traveled to India. I took extra vaccines. My children have taken all the vaccines. Family members of mine have elected to take the COVID-19. It's a personal choice. It should always be a personal choice. It's a part of medical freedom. People should always have the freedom to make a medical choice, right? What we're seeing is a linkage of three circles. Medical freedom being taken away, having medical freedom linked to social freedoms taken away, and then economic freedoms. But what's happening to me is all three. So since I signed my separation agreement, and I started in a private practice, but maintained my hospital privileges at 2 Baylor Scott & White hospitals, the day that Baylor Scott & White announced their employee vaccine mandate. Now, I can tell you, across our health system, there's been no employee outbreaks. Mm-hmm. Our health system, as I've told you, had one of the premier early prophylaxis programs with hydroxychloroquine. We've published a lot on COVID-19. We've done a great job with COVID-19. I love Baylor Scott & White. I was at Baylor University Medical Center when I was a student 30 years ago. Mm-hmm. It's an absolutely terrific place. Have great relationships there. Have a terrific research program there. With the termination of my contract at the end of January, early February, I gave up my titles there as Vice Chairman of Medicine, Program Director in Cardiology, and Director over Research. I gave up those titles. No longer were employed by Baylor Scott & White. Now I'm employed in a private practice. But since that time, I have gotten a letter from Texas A&M, despite meeting all my professional continuing credits for Texas A&M, that my professorship has been canceled.
Wow.
I've been notified by Texas Christian University, University of North Texas, which I barely got going with as a teaching faculty there, that professorship has been stopped or terminated. No
Any
reason.
reasons?
No reason. No, just like no reason.
Yeah.
And then the day the vaccine mandate was announced for Baylor Scott & White, there was an announcement in the newspapers, both newspapers in Dallas, that Baylor Scott & White Health System was suing me. And they were suing me for violating my separation agreement, stating that I was using my prior employment and titles in media appearances. In the court filings, they pick examples where in a media presentation, there's some post-media processing where a banner is put up.
Yeah.
And it turned out the most common profile that was being used was the first one that came up on Google. Mm-hmm. And the first one that came up on Google was from the Cardiometabolic Health Conference that was 2 years ago I presented at when I was employed by Baylor Scott & White, and that's actually put on by Harvard, a very prestigious organization. So the idea is, a prior profile, and I don't have any control over that. I always stated my own views, and I always followed all the talking points, and I never said, I never spoke on behalf of any entity that I'm related to, and I still don't today. So, I was quickly alarmed, and my wife and I are very generous donors to the Baylor Scott and White Health System Foundation.
So you're supporting them to sue you.
My wife and I, we have an endowed scholarship at Baylor University in Waco. So there's a lot of Baylor confusion, right? So, and my son's a graduate from Baylor University, and so I am well known. The name Peter McCullough and Baylor are very tightly aligned. That is never going to go away. I mean, you can't take away my college degree, right, or my endowment.
Can't rewrite history. I mean, you did work there.
Yeah, and I worked there. So my former roles are my former roles. So we have filed a motion to dismiss what's called anti-SLAPP lawsuit, which means it's a strategic lawsuit against public participation. And this is grinding out at the very slow legal pace. But this is an example of a health system, which, by the way, instead of using internal attorneys, of which they have plenty on the payroll, they got outside external counsel, I'm sure at some expense, to try to prosecute me. So, and I'm a doctor, I bring patients to the hospital. I have patients flying in from all over the country to the hospital. So as I'm taking care of patients in the hospital and in my clinic, which is within the hospital, I am being sued by that hospital. And it's created enormous anxiety. My family is anxious. I am legally and professionally and financially threatened by a multi-billion-dollar health system. I feel very threatened by the statements from the Federation of State Medical Boards and by the American Board of Internal Medicine. I've just been canceled out of Texas A&M, Texas Christian University, UNT, and I've been canceled out of my prior job. The question is, how much more can be lost? I mean, I'm trying to survive as a doctor. My opinions are heavily sought. I mean, I can tell you, I have had conversations with senators, heads of state, religious leaders at the highest level, economic leaders at the highest level. I'm a frequent commentator on Fox News, but I've been on many other news stations as well. My interpretation of the data, as it has been through this interview, has been pinpoint. I am here in Salt Lake City, Utah, to meet with other important officials after this. People want my opinion because I am giving information. And under no circumstances can I ever be accused of giving misinformation. I want the listeners to hear that clearly. That will be fought. If that statement is ever made or that accusation is ever levered that I am giving misinformation, that will be fought with the full force of defense, with every citation that exists, because I am absolutely pinpoint, and I am telling people right now, I am telling the fact checkers, bring it on. And I mean it, bring it on. Every time a fact checker has even questioned what I've said, they have been incredibly embarrassed with what they've done. Incredibly embarrassed. I had a fact checker when I testified under oath in the Texas Senate. That means I am giving my opinions, my personal opinions. My opinions are not subject to fact checking. I had a fact checker, a French journalist, try to put a big X over me on social media that I gave an incorrect fact during my Texas Senate. And so that was a point of shame. Why is a French journalist fact-checking me in French on my testimony over the Texas Senate that dealt with many local issues like the availability of monoclonal antibodies and herd immunity, et cetera? And so there was a very strong rebuttal in the whistleblower's newsroom to that French journalist. On another example, another journalist, a fact-checker from Hong Kong, who had ties back to one of the vaccine stakeholders, was trying to, again, put a fraudulent piece out on me there. And so
it's attack, really. It's not honest fact-checking, it's agenda fact-checking, basically.
It's an attack, and I can tell you, I have never attacked anyone. And anyone listening to this interview would understand that I'm being enormously respectful. I am not calling people out by name. I'm not making ad hominem attacks. I've never done so. I never will. This is about scientific discourse. This is about a pursuit of the truth. This is about saving lives. People are miserable in the hospital, vaccinated and not vaccinated right now. They're in the hospital. They're fighting for their lives. Sadly, people are dying, vaccinated and not vaccinated. So this isn't about the vaccine. This is about saving lives and compassionate treatment and using the best tools that we have to get us out of this pandemic. We're a year and a half into this. Some think, honestly, without the vaccine, if we just had a big push on early treatment, this could have been like SARS-1. We could have closed this down in a matter of months or maybe a year or less. But instead, we just, with the suppression of early treatment, allowing the infection to rage, and now failure of the vaccines promoting the Delta variant, and now everything that's brought, that the vaccines have made things worse.
I was looking, it was, I forget the journal, but it was a biostatistics journal, and the guy, it was interesting how the authors were trying to still sound very pro-vax, but they said, hey, we can't give it too much credit. And they were looking at the rates of infection, month by month over a period of several months. And from its peak, it was down, I think, and again, fact check me, it's somewhere in the 80s. I think it was 86% or so. And that's when the vaccine got introduced, is when it was already, and he said, we need the vaccine to finish the job, as they put it, but we were already 86% down the slope of it, and this is probably right before Delta, and then Delta spiked it.
There's a couple milestones, and there's a few. Again, the fact checkers, we can be roundabout in our interpretations and show the figures. But if we look at from day one of the pandemic in the United States to day one of the first vaccine being made available to present time, roughly half the deaths have occurred in the pre-vaccination era, and the other half have occurred in the vaccination era. Okay. Israel, we're looking at Israel closely because they're just ahead of us in vaccines. Israel can predict for us what we're going to see. And in Israel, they were the darlings of the vaccine world around March, April, right? They really got out there and they vaccinated hard. And it's a self-contained country. It's a varied country. It's an interesting place. But people following the rules made available to them. What we have now is Israel's pre-vaccination peak and then their post-vaccination peak. Their post-vaccination peak is bigger and badder and worse with Delta than their pre-vaccination peak. Iceland's seeing the same thing. I think there's going to be case after case after case. From a population perspective, we just can't make the case that the vaccines are doing good on a population level. On an individual level, we'd love to think this is the case. So for instance, people have said, Dr. McCullough, if the vaccines can't stop COVID-19, is there some consolation prize? Is there some secondary benefit? Does it make the illness less severe? I've been following the CDC data, and we don't have a way of looking at this, but they do. I mean, they put up deaths and hospitalizations on their websites of those who are fully vaccinated. That's what the CDC has, several different time points, July and August, and the listeners can go look at that, and the viewers, and just see what you think about that. Right. There's not a way of figuring out is this a vaccine benefit or not, but it's a way of saying in large numbers, people can be fully vaccinated and be hospitalized and die. That's the conclusion that I think one can safely draw from the CDC data. My personal impression, though, managing patients who've been vaccinated, I do have an impression that the vaccine makes the illness easier to manage. I do have that impression. I have several patients in my sphere and people I know who've taken the vaccine and they've gotten COVID-19 and they haven't had horrific complications and they've been manageable. I got called by one last night, however, a fully vaccinated man who's in a hospital in Washington State, and he's loaded with blood clots in the lungs and all over. And the daughter was reaching out to me saying, could the vaccine have primed him for all this excess thrombosis? So I don't know. I mean, I think if I could put a positive report on this, I would say I'm hopeful that the vaccines are still doing something to reduce the incidence of illness. It looks like, unfortunately, it's not going to be good enough to make a case for mass vaccination or mandates. And I hope those who take the vaccine, we sincerely hope that all the safety risks are behind them, that in front of them there are no long-term things to worry about, and that if they do get COVID-19, that it's a milder case. I think that would be the most favorable way to summarize it. If we push forward with vaccine mandates and vaccinating people against their will, and then putting boosters, now continued injections of genetic material, I have a different view. I think things are going to look really bad. People are going to be very, very uncomfortable. If we're going to vaccinate somebody who doesn't want to take the vaccine, they are far more likely to report a safety event. They're far more likely to be upset about their employers or the people who forced them into vaccination, right? They're just going to be primed. They're like, listen, I don't want this. It's going to make me sick. Now I'm sick. You can see how this is going to happen. The other thing is, if from shot 1 to shot 2, there's a step up in safety risk, shot 3 invariably is going to be another. The spike protein and the genetics that code for it, it makes every bit of common sense that this is not going to be good. Now, another favorable thing on the vaccine agenda that I could say is Novavax. Novavax is a non-genetic vaccine. It's a spike protein, 5 micrograms of spike protein. If it could be adjusted to cover Delta and have some modifications, taking like a tetanus shot, I mean, if we had a susceptible person, let's say we did have a senior or we did have a nursing home worker and they were at risk and susceptible, who wouldn't want a tetanus shot there? Would we broadly apply it to people your age and my age and children? No. I don't think there should be any broad application. I think Linus Pauling was right. We should never vaccinate people for the common cold. No. We should only vaccinate people who have a real risk of hospitalization and death with COVID-19. That I think everybody should agree with that. If that risk is way less than 1%, we should never vaccinate somebody for a less than 1% outcome.
Yeah. Well, and that's, I think in summary, it does get kind of disturbing if it's something could potentially be catastrophic if the agenda is driven to get a needle in every arm, then additional needles. We just saw a couple of people leave the FDA, I guess, over the booster shot. Do you have much insight around that, incidentally?
Well, I do know is Dr. Gruber and another official, very senior, and this vaccine regulatory division of the FDA, this is their Super Bowl, if you will, right? You're in the biggest time ever, the biggest program ever. The FDA and CDC are sponsoring this program. Boy, this is it. If you're going to be a vaccine regulator, this is it. Dr. Gruber signed the conditional letter of approval to Comirnaty. She was party to, I think, this false talking point that Pfizer was approved when it wasn't. Dr. Gruber and another official resigned right in the middle of the Super Bowl. Do you know how much internal knowledge there is with the briefing booklets, the data, what's called the regulatory dialogue that's happened over time? I think to walk out, I think that is an alarming signal, very alarming.
Yeah, it was really kind of shocking and unexpected, but something happened that made them very concerned.
It's not a good sign.
It's not a good sign, yeah.
One would not take that
There's
as a
no
good
positive
sign.
spin to put on that, yeah. Well, I feel like we could speak for hours. You're encyclopedic in your knowledge, and to use your word, also very pinpoint.
Thank you.
I don't see any sloppiness or laziness around the things you're saying. You obviously have a great ability to retain literature review and to contextualize it. This has been just an extraordinary journey that is required. I mean, there's too many headlines around all this, and people are getting, it's kind of, there's a confirmation bias based on headlines. If I feel one way about it, I'm going to find all the headlines that make me feel my way, and then somebody feels a different way is going to find their headlines. In your case, in the way that you presented this, it really is now, okay, here's all the resolution of this picture that can have you really kind of see it and then come to your own conclusions. And you did that extraordinarily well. So just thank you for your time in doing this.
Thanks. I think that's a fair summary. I can tell you my commitment to the science and the data and to be able to cite and locate and present that data fairly to America and the world. I honestly believe the world depends on this. Yeah. I can tell you my family depends on this, and I can tell you personally and professionally and economically, I depend on it. Yeah. I depend on the fair representation of scientific information, and under no circumstances and at no time will I ever or have I ever given any scientific misinformation.
Well, that completes part 3 of my 3-part interview with Dr. Peter McCullough. As you can see, we spent a lot of time having this conversation. It probably could have even gone on longer. Bottom line is this man is eminently qualified, extraordinarily intelligent, and passionate to share this information with the world. It has to get out there. I hope once you've gotten this information, you'll share it too. Thank you for being here. Welcome to part 2 of my 2-part interview with Dr. Brian Hooker. If you saw part 1, you recognize how brilliant Dr. Hooker is and how committed he is to getting to the truth when it comes to things around vaccines and in COVID in general in this world. And certainly his background and experience gives him permission to comment on this. He's got great insights. We really dig deeper in part 2, so let's jump right in. Now I want to move into another subject that I think is kind of important, because it's another thing that is a part of the leverage being used to say that everybody must be vaccinated, and we are within our rights to try to force everybody to be vaccinated. And here's why: we have to create this thing called herd immunity. Can you explain, words used all the time, nobody explains it. What is herd immunity, and is it a valid construct?
Herd immunity is a concept that was established around measles outbreaks in the Baltimore area in the 1930s. And what was found was that when a community had approximately 60% natural immunity, then that community would become immune to the measles, and the measles incidence would drop in those communities. It was not based on vaccine immunity, it was based on natural immunity. Natural immunity is robust immunity. It's not just B cells, which can be stimulated by vaccination, but it's also T cells that are often not stimulated by vaccines. So you get antibodies, and you also get natural killing action of natural killer cells in the immune system. And so it's important to reflect that, because natural immunity is much more perfect than vaccination or artificial immunity.
Right.
Okay? Now, to reach a level of herd immunity, you have to have a vaccine, or you have to have natural immunity where transmission is prevented. Okay? So that's the key here. If transmission is not prevented, there is no such thing as herd immunity.
But how does that work, though, as far as saying, okay, if 60, 70% of a populace is considered immune, and again, if it's natural occurring disease that they have acquired immunity from, that might be one thing, and you can't make the same claim, especially today with the vaccinated, because the breakthrough infections rate for the vaccinated is climbing like in a startling way, and we'll get to that in a few moments. But if 30%, so are they basically saying that once a certain level of the herd has some level of immunity that prevents transmissibility, now somehow the rest of the herd is also protected? I mean, is that the theory, and does that hold, because you still have people that don't have immunity that could be exposed?
That is correct. I love the way you explained it. When you have, say you have 60% herd immunity, so 60% of the herd is immune, and if they contract measles, or if they contact somebody with measles, the measles will go no further. It will stop in its tracks. That still leaves 40% of the individuals that are susceptible to measles. Now, in a congregate setting, then those individuals can still get measles, but in general, if you have 60% herd immunity, then the 40% goes out, mingles with that 60%, and the transmission of measles doesn't stop completely in its tracks, but it goes way down, because once it transmits from an individual that is not immune to an individual that is immune, it just stops in its tracks. So at 60%, there's enough intermingling between those two populations, those that are immune and those that aren't immune in a community, not to stop it completely, but to stop, say, an epidemic and have it go down to an incidence where we'd say, oh, well, we have a few sporadic cases of measles.
So it's basically, herd immunity is basically sort of mitigation. It's not like suddenly, we have this dome of protection around all of humanity. It is basically saying it's going to mitigate serious outbreaks that affect a bunch of people. And the amount of mitigation, I don't think anybody can do the math to really know what it's going to be. It might be a lot, it might be a little. But because here, again, this gets back to the compulsory arguments as far as saying, now we can force vaccination because at herd immunity, X, Y, and Z. But let me ask a question. going back to the example of measles, and let's say it's 60-40, back, I think you said in the 1930s, that's what they asserted, that, that once you hit 60% immunity, and that was natural immunity, there's considered sort of this generalized protection of the herd that it's going to mitigate the amount of measles that happens. But does the person who is in that herd, who's a part of the 60%, who has immunity, do they have anything to fear from the 40%?
The 60% has absolutely nothing to fear from the 40% because natural immunity is, by definition, much, much better, if not perfect, okay? And when you look at the overall repeat incidence of even COVID-19, it's much, much less than what we see in those breakthrough infections of individuals who are vaccinated. So natural immunity is much, much better. There's a study that came out of Israel that shows that natural immunity of COVID-19 is at least 13 times better in preventing transmission compared to vaccine immunity.
So the statement, if I were to make it, and then I want to talk about what you just said in Israel right after, but the statement, if I were to make it, saying, hey, listen, if the vaccine works, and you have nothing to fear from me being unvaccinated because you think you have immunity, and if you think it works, and you have immunity, then why are you worried about me who's not vaccinated? Now, could they try to make a counter argument saying, yeah, but I could get a breakthrough infection because of you. Well, then you can get a breakthrough infection from a person who's vaccinated also. Am I right?
That is correct. Once they make the argument that their immunity is imperfect, that abolishes herd immunity. So you can get a breakthrough infection transmitted from somebody who's vaccinated. You can get a breakthrough infection that's transmitted from somebody who's unvaccinated. And there is no level of herd immunity that will prevent that. That will cause, you can't take an imperfect vaccine and compare it to perfect or near perfect natural immunity and make a valid comparison.
So then it's absolutely absurd when people try to assert we have a pandemic of the unvaccinated, for example, or the unvaccinated people are going to cause other people to die who otherwise wouldn't have.
I hate that term, and I hate that false assertion. We've heard it over and over again. That's a talking point of sort of this totalitarian construct that is sort of overwhelming us right now. Is that this is a pandemic of the unvaccinated? Well, you can look at the data and you can see something very, very different. If you look at the number of breakthrough cases in different incidences, the breakthrough cases in Provincetown, Massachusetts, when they studied that, 74% of those individuals in that outbreak had been previously vaccinated.
And any person on any side of this argument would assert that if you got 74% vaccination, you got a herd. Or would they try to argue where there wasn't enough of a herd?
They would try to argue that. They wouldn't be correct because if you're looking at the herd, you're also looking at the proportion that was vaccinated that didn't get the infection as well. Okay. Now, herd immunity.
That's a great point, Stanley. I didn't think of that, but that's a great point.
Right. The herd immunity is been sort of this drifting figure. If you talk to Tony Fauci, he started out at 60%, then went 70%. Who knows? He might get to 95% vaccination, and certainly President Biden would love us to have 95% vaccination, and would love to mandate us into oblivion in order to get that particular percent vaccination. But I'm telling you, no level of herd immunity is acceptable when there are breakthrough infections. When you have breakthrough infections, then you have a virus that's continually mutating in the backdrop of vaccinated individuals that provides selection pressure in order to thwart the vaccination, then the breakthrough infections, as the virus mutates, are going to become worse and worse and worse.
So let's keep following that chain of logic. So we had in Massachusetts, in that small community, right, where they had 74% vaccinated, right? I don't remember the exact numbers, but I remember that it was sort of a sequestered area, meaning that they weren't out like, traveling through airports, but it's kind of like this sort of tight little petri dish, if you will, of a community that suddenly they had this large outbreak. So, what do you know the numbers? How many people got infected?
It was about 150. I want to say 148, but I don't think I'm correct. But it was about 150 cases in this community that happened to be locked down at the same time. Wow. It was more of a state that had more measures, and Provincetown, I'd say, is probably more of a compliant community, and so these people were taking the measures that the government was telling them to take.
So they're basically locked down. They've got 74%, and out of the 150 or so that were infected, do we know the proportion of how many of them were vaccinated versus how many were unvaccinated?
Well, so if it's 74%, then approximately 37 in the outbreak were unvaccinated, and then the rest, 100 and some odd, 111.
Oh, so it was
13.
proportional?
Yes.
Meaning that, basically the proportion of vaccinated to unvaccinated was the proportion of people who actually got it, which almost shows that in other words, there's zero difference. Whether you're vaccinated or unvaccinated, you had the same absolute risk in essence.
Exactly.
Yeah.
Exactly. It was proportionate. So in that particular instance, for every one unvaccinated individual that got COVID-19, there were 3 vaccinated individuals.
Wow. Which was basically the proportion of the population vaccinated to unvaccinated.
That's correct.
How did the CDC try to explain this one?
I seem to remember I read they had a report in their journal called Morbidity and Mortality Weekly Reports. Mm-hmm. I seem to remember that they called this an anomaly of breakthrough cases. Okay,
so now that was a while ago, so it's an anomaly. We can't explain it, it's just an anomaly. Nothing going on here, don't look over here, basically.
Exactly.
But now, is it an anomaly? Because let's look at Israel. So Israel, by most scientists, I think no matter what side of this debate they're on, whether they're very much pro-forced vaccine and we need to get vaccinated, or if they're more on the side of saying, this is an atrocity, we can't be, vaccinating into a populace like this. And for the reasons you had mentioned briefly earlier, maybe we'll talk about the pressure you're putting on the virus to mutate, and we'll talk about that in a moment because it's going to be relevant here. But almost everybody's looking at Israel saying, okay, there we have roughly 74% fully vaccinated in their population. Is that the number?
If you look at adults that are that are qualified to receive the vaccine, and now I believe that they're also giving them to children that are 12 years and up. Mm-hmm. It's 85.
85, okay.
85% vaccine compliance because of the aggressive use of mandates and vaccine passports in Israel. They have achieved about 85% compliance.
So 85%, I mean, that's, Fauci's dream, right? If we could get to 85, Biden's dream, anybody's dream. If somebody who's for this 85%, we should be in a scenario that is we won the war against the virus, right? We eradicated it. So so Israel is looked at as the harbinger, saying they're some months ahead of us because they started their program months before maybe the U.S. and several other countries. So at the same time, we are seeing alarming data coming out of Israel with their 85% vaccinated population. So can you speak to what that data is?
I've seen data I've seen 2 different sources of data, and the data that I'm going to quote is from the Israeli Ministry of Health. Mm-hmm. Shows that the number of cases among the vaccinated, and these are cases that required hospitalization, mm-hmm. not just cases of COVID-19, that 88.6% of those were fully vaccinated. And by meaning fully vaccinated, at that particular time, it meant that they got 2 shots of the Pfizer vaccine or 2 shots of the Moderna vaccine, and I'm not sure how many shots of the AstraZeneca vaccine, which is also, I'm not sure if that's a 1 or 2 dose course, but they were considered fully vaccinated for those 3 particular vaccinations. So in that particular instance, 85% vaccination rate, but yet 88% of the cases that required hospitalization were among the vaccinated. So that is the ultimate example of breakthrough.
I mean, it's startling, and again, it's sort of like the Massachusetts thing, where about the proportion of vaccinated to unvaccinated in the populace is about what we're seeing in the hospitals. It doesn't seem to matter. Am I looking at that accurately? Because you're saying 85% are vaccinated, 88%, actually more than the vaccinated population, are hospitalized with severe COVID. You know, it's roughly the proportion of unvaccinated to vaccinated people who are in the hospital experiencing severe COVID.
That is correct. And this is substantiated information. The reason why we go back down to the Provincetown, Massachusetts study is because it was validated by the CDC. Mm-hmm. The CDC is actually showing numbers of cases in that particular instance. I've seen anecdotal reports and I've seen memes from the CDC that I don't trust because they're not based on data. And they reflect and they seem to indicate that there are more hospitalizations in the unvaccinated. But I know that what is coming and what we would expect from countries like Israel and countries, also the tiny country of Gibraltar, which has over 100% vaccine compliance.
How do you have over 100%?
Because of visitors coming in and
okay,
out, they get counted that aren't a part of their stable population. So they have a population of about 30,000 individuals, and right now they have 4,000 COVID-19 cases.
Wow. Which 100% are breakthroughs.
100% are breakthrough cases.
And it doesn't sound like with 30,000 people and they have 4,000 cases that, that's a high percentage of that's over 10% of the population that's experiencing it, which is really high. That'd be the equivalent of, in 330 million here, of 33 million active cases. So it's much worse than here.
It is much worse than here, and it is literally 100% vaccinated population. So the idea that the vaccinated can't transmit, totally blown out of the water. The idea that the vaccinated won't get severe cases, many of these are hospitalized, and I think they had about 120 deaths.
Wow.
Okay, so any remnant of fact that it's preventing mortality, blown out of the water.
Wow. And talk about having a great isolated group to study. I mean, Gibraltar is a pretty isolated place.
Exactly.
And they weren't letting anybody in without a vaccine, and everybody there was vaccinated. So that's, you can't get better herd immunity. If you buy that particular prospect, you can't get better than there. So we have reference data. It's not speculative because a lot of what's going on is inference, right? Well, we are inferring this from the data, and I would say that, hey, everybody here is suffering by confirmation bias, right? They have a certain view of things, and they're finding the data that sort of validates their view, which is not what science is supposed to do, but nonetheless it happens. But when you look at Gibraltar in the way you described it, I don't think there could be any confirmation bias. It's pretty clear. Everybody is vaccinated. So what happens if you get everybody vaccinated, and here's the data, and that data is pretty damning?
Absolutely, and I'm loath for a lack of good data coming from the United States, because when you look at what the CDC is publishing from theirs, what the CDC is publishing from the Vaccine Safety Data Link, they sidestep all of these issues. They will sidestep, and they will give you worthless data sets, and claim a high level of protection and a lack of adverse events. But we have to fall back on, again, the Provincetown, Massachusetts study, because it's the only time that they've ever published real information. I'm very, very thankful that the Israeli Ministry of Health is actually publishing real information, and that we can get the data from Gibraltar as well. We have to use these examples because the confirmation of bias, like you said, is so bad in the United States.
Well, talking about how to mislead and misrepresent with data, and I had a friend send this to me recently who I'm having a back and forth with on this, and he basically said 95 to 99% of all hospitalizations are unvaccinated from the CDC. Now, you probably saw that particular statement, But I said, did you look at when they actually collected that data? Because it was when nobody was vaccinated. So you
That's
said,
right.
Do you know what I'm talking about?
Yes,
yeah.
I know about that study, yeah.
Yeah, so, I mean, how did they get away with that? Because I think, and I might be a little bit off here because I know everything gets fact-checked nowadays, but basically they looked, I think, January to April or June of 2020, was it? And, very small percentage of the populace was vaccinated. So, of course, anybody who's in a hospital is not likely vaccinated, and it makes the numbers look high. So is that an accurate depiction of that particular stat?
Absolutely, absolutely. That is an accurate depiction, and I hate to say this, but CDC researchers probably closed down on that particular window in order to fit that narrative. Okay, so it's data cherry picking in order to fit a particular narrative. The CDC is the master at data cherry picking. They did it in the autism studies that I FOIA'd back in the early 2000s. They would, if they didn't like the results of a particular clinic within an HMO that they were studying, they would just throw out that clinic and you would be none the wiser. Okay,
Right.
so this is the same CDC that is bracketing this information for when a very, very small portion of the population was actually vaccinated, and even worse, fully vaccinated, realizing that for Pfizer and Moderna, the most prevalent vaccines, it took 2 doses. And so anybody that didn't fit that tight metric, meaning 14 days after their second dose, they were considered unvaccinated. Okay, so that's why that study appears the way it does.
And I mean, wouldn't they know that people are going to see, through it? I mean, and that it would be egg on their face. And that's the thing that surprises me. It's almost like an arrogance that says we're going to feed them. Pardon my language, but we're going to feed them bullshit, and they're going to be none the wiser. But it's so obvious that because they have to basically say the data set comes from this period of time. And anybody looks at it, you don't have to be a scientist to look at it and say this is them trying to lie. Because this is the interesting thing we talk about. What do we mean by lie? The data is accurately reported, in the sense of saying, 95% of the people in the hospitals